All right, guys, let's get on to cardiology. So we're going to talk a little bit about what the heart does, why it's so important. We are going to see a lot of cardiac calls as paramedics. So it's unavoidable. The heart is pretty much the number one thing that fails when people call 911. So as dubious distinction of being the leading cause of death in the United States, which is acute cardiac syndrome. It's estimated at more than 62 million Americans have some form of cardiovascular disease, CHF, angina, hypertension, all those problems. Approximately 7 to 8 million people per year will seek treatment for chest pain. Of those, 2 million will have an acute myocardial infarction and 500,000 will die from heart attacks every year. Realistically, a lot more people will die from heart attacks, but these were the ones that die solely from heart attacks rather than from the eventual lethal dysrhythmia of heart attacks. A lot of them are going to die. Half of those will die within the first hour of the onset of symptoms. In other words, massive heart attacks right away. That's what kills people the quickest. ACS is a term that covers a cluster of clinical signs and symptoms related to diminished blood flow to the heart. ACS is commonly related to atherosclerosis, but it can be related to other pathologies such as aneurysms or vasospasms. Remember, atherosclerosis is the thickening of lipid buildup within the vein, within the vasculature over time. I like to think of it as the TH as thickening. The other one, arteriosclerosis, is usually caused by old age, and it's a hardening of the vasculature as it becomes less elastic. The muscle becomes less effective at contracting and dilating, so it hardens. Art, hard, atheros, thickening, TH. That's how I've always remembered it. Ranges from mild chest pain with exertion, this would be stable angina, or angina, however you want to pronounce it, to acute myocardial infarctions with muscle damage and death that can lead to CHF, chronic congestive heart failure, and even cardiogenic shock. So angina, probably the most benign of these. It comes in two types: stable, which happens when we're being active, and when we rest or take nitro, it goes away, and unstable, where it does not. It's also called pre-infarction angina, meaning that the heart is now in damage. This means that the heart is ischemic, aka entering into anaerobic activity. It's not getting enough oxygen. It's going to start acting up immediately and letting you know that it is not happy. Some people, this is as little as just getting your heart rate up to about 100, 120, and it'll happen. By the way, it's really easy to get your heart rate up. I'm a really healthy guy. My heart rate's probably about 60 when I'm laying down. But if I go for a walk, my heart rate can easily get up to 100, really, really quickly. So it doesn't take much for this to happen if you have a bad heart. There's also one more we're going to talk about here real quickly. It's called Prinzmetal angina. These are spasms of the coronary artery, causes diminished blood flow to the heart. Coronary artery is the arteries that supply blood flow to the heart. They start spasming. They're not sending out blood as efficiently. This is different in that it's not really going to be affected by nitro as much. Most important thing we can do is rapidly identify them, usually done by their symptoms, chest pain, maybe nausea, maybe a feeling of impending doom, as well as things we can look at. Their skin signs, usually going to be a little bit pale, a little bit sweaty, maybe even a little ashen gray. They might be a little blue around the lips. They might have radiating pain to their shoulder or jaw. And then finally, we can look at that good old 12 lead. ABCs, oxygenation, aspirin. Aspirin is a platelet deaggregator. The reason we give aspirin for cardiac emergencies is because if there's any chance of clotting, this is going to prevent any further clotting. It might also break up some clots. However, aspirin is not a fibrinolytic therapy. It is just an antiplatelet aggregator. Nitro will help. Nitro is a systemic vasodilator. Better than nitro would be epi, because epi is a peripheral vasoconstrictor and a cardiac vasodilator. Nitro is just a system-wide vasodilator. And then transport with the EKGs. So here's showing some atherosclerosis. So fatty deposits build up. Now let's talk about heart attacks, acute myocardial infarctions. Chest pain is the big symptom here. Cannot be relieved by nitro. Radiating or not, squeezing, pressure-like, shortness of breath, nausea and vomiting, diaphoresis, anxiety, changes in rhythm, and dysrhythmias. May present differently in women. This is a big consideration. Why do women present differently for heart attacks? We don't really know. The generalized theory is that men compartmentalize pain in a different way than women do. This can be demonstrated in a couple different ways, because we can look and see that some women, they give birth, right? And in order for them to do that, they have to interpret pain in different ways. However, when we do tests to see how men and women perceive pain, men actually can deal with pain better than women can. So it's not that women are necessarily better at dealing with pain. It's just that women deal with pain in a different way than men do. But women can present without even chest pain. I've seen women have heart attacks where they're having like back pain or like pain in their shoulders, anxiety, and then sweating, and then this kind of like anxiety is the biggest one with the back pain. So I've seen that before too. There are other patient presentations which will present differently. Diabetics and obese patients. How do we treat heart attacks? Pretty much the same ways we're treating a chest pain. Aspirin, nitro, oxygenation, EKG. Maybe you guys remember MONA. MONA used to be the acronym we'd use to treat chest pain or heart attacks. It stood for morphine, oxygen, nitro, aspirin. Morphine might be indicated, might not be. Morphine has good effects on the cardiac vasoconstriction, but not everybody carries morphine anymore. Here in San Diego, we gave up morphine and we got fentanyl and ketamine, which are great, excellent, but they have different effects. So can't give ketamine for cardiac chest pain. We can give very small dosages of fentanyl. All right. Finally, we call it a STEMI once we can verify that it is a myocardial infarction and we're seeing EKG changes. STEMI stands for ST elevation myocardial infarction. And we'll go over that again in a second. I guess we're going to go over that right now. So again, remember the ST segment. Remember, and we're talking about EKGs. I just realized I turned on my. There we go. We're talking about EKGs. There's a couple different structures. The P waves, QRS, and then T. When we're seeing this S to T elevation over the baseline, that's when we're seeing ST elevation. So again, normal sinus rhythm, P, QRS, and then the S goes into the baseline, and then we'll advance into this. When the S goes straight into the T, that's elevation. But elevation in one lead does not a heart attack indicate necessarily. We need to see it in contiguous leads, meaning leads that are looking at the same area of the heart to confirm which area of the heart we're seeing this heart attack in. So, for example, here we're seeing a 12 lead. So we've got 1, 2, and 3, AVR, AVL, AVF. These are the normal leads. If you put on a 3 lead, you can get all 6 of these leads. By the way, it's always really bothered me that we call it a 3 lead. Here in San Diego, everyone calls it a 4 lead. A lead is different than an electrode, all right? You put 4 electrodes on, unless you're in the hospital, sometimes it's 4, sometimes it's 3, sometimes it's 5. And we can look at up to 6 different views of the heart, all right? So a more accurate way to call it would be a 6 lead or a 3 lead if you want to think about the 1, 2, 3. Then a 12 lead obviously is looking at it from 12 different directions, but we're using 10 stickers, all right? So again, an electrode is different than a lead. People generally tend to use them interchangeably. Keep in mind, which ones we're seeing elevation in will determine which area. In this one, we're seeing no elevation in V1. These are the precordial leads. No elevation in V2, maybe a slight. V3, V4, V5, and V6, all are showing that. Remember, these first two are septal. V3 and V4 are anterior, and V5 and V6 are lateral leads. So this would be an anterolateral myocardial infarction because we're seeing it in two different contiguous areas. If we were only seeing it in 3 and 6 and not in 2 and 4, we couldn't call it a STEMI. We could only call it a chest pain with EKG changes. And we'd say we're noting ST elevation in V3 and V6. That might be indicative of other things. It might be that our electrodes are in the wrong place and we're getting readings slightly off. Anytime you're seeing elevation, though, is cause for concern. When in doubt, call it a STEMI alert to the hospital. Pre-hospital system may bypass the emergency department in favor of direct transport to a heart cath lab. Catheterization is the only real way we have to deal with a heart attack. We need to insert something into the blocked off artery and make it bigger so that blood can start flowing in there and we can get oxygen in there. It might be too late. In fact, it probably is. In fact, probably some of the heart has already died. Usually this is the case. In fact, our heart can die all the time. You and I probably have certain tiny parts of our heart that are already dead. Tiny little infarctions, tiny little bits of chest pain. Now, realistically, that's not really going to be a concern until later in life, but we can live with up to 25% of our heart dead before we will start to feel the effects of cardiogenic failure or congestive heart failure. How do we treat a STEMI? The same way we treat a heart attack, duh. Here is what we would do in the cath lab. They might do a balloon angioplasty, put stents, or do a CABG, which would be a coronary artery bypass surgery, or a bypass graft is a CABG. S is for surgery. A balloon angioplasty is just what I said. You put in something that expands it so that blood can flow through. It's going to permanently change the shape of this. A stent is essentially the same thing, but it puts like a wire mesh there so it'll hold the vein open, or sorry, hold the artery open, or arterial or capillary or whatever it is that's getting blocked off. And then finally, there's the bypass graft. So blood comes out of the aorta and it supplies the heart. This is a really good representation of it. But if the blockage is somewhere in here, we might just forget the block entirely and just put a graft right in here. We'll usually take an artery from your thigh or your leg and we'll put it right in there because those are the only ones big enough and strong enough, right? This is going to be under a lot of pressure. Your aorta is the highest level of pressure in your body, up to and over 200 millimeters of mercury systolic on every contraction. So you need a very big, strong artery to bypass that. Now, again, like I said earlier, we're talking maybe about administering thrombolytic medications in the paramedic field. Thrombolytic, thrombus, remember, is a buildup of plaque. Lytic, lyse, is the same thing that happens to our cells. They break. So it's a clot buster. You guys, I'm sure have heard clot busting drugs. Thrombolytics. Although the administration of any thrombolytic will be based on your specific protocols, it might become a thing in the future. Now, I wondered, why don't we just administer thrombolytic medications to patients that are at risk of a heart attack, right? Why are we wasting our time with blood thinners and all that other stuff if we can just give them something that's literally going to break up all the clots in your body? Well, because that's very dangerous. We don't want to break up clots in our body because our body is healing stuff all the time. Capillary beds are breaking in your body all day long. Your body is healing things you're not even aware of. When you guys give me a standing round of applause at the end of me teaching today, you're actually breaking millions of capillary beds in your hands. Just sitting on your butts to listen to my beautiful voice all day is breaking capillary beds in your butts. Every time you move, walk, breathe, cough, everything, you're busting capillary beds. Your body's healing that all day long. If we interrupt that healing process and we start breaking up all those thrombin clots that are forming, we're going to have some severe damage to that body. Thrombolytic medications are not good for you, okay? But they're better for you than death. And that's kind of the argument that we make for administering them in the hospital. Are thrombolytics good for you? Absolutely not. They are terrible for you. No one should take them under any circumstance unless you're dying of a heart attack. Then it's okay. But, you know, we do a lot of things to people that are dying that they probably would not want done to them otherwise. It's just kind of the name of the game here in medicine. All right. I was skipping over the rest of this thrombolytic stuff because we don't need to know about it specifically. There's lots of contraindications for this thrombolytic medications is the main part here. All right. Let's move on to congestive heart failure. Now, this is an important one, and it's important to distinguish this from regular, different types of heart failure, because we're going to combine all of these: left heart failure, right heart failure, congestive heart failure, and acute pulmonary edema. So heart failure is a disease of significant concern, about 1 to 2% of the adult population, more than 400,000 patients diagnosed every year. 40% of them will be hospitalized every year, by the way. So that's why we're going to see this at hugely disproportionate rates. Heart failure, referred to as CHF or congestive heart failure, is a pathophysiologic state in which the heart cannot pump the blood needed to meet the venous return of the body. In other words, we have a mismatch in preload and afterload. This drop in cardiac output results from a buildup of fluid that occurs as a result of pump failure. This is caused when the right, left, or both ventricles fail to meet the body's needs. Let's break this up. It may be a chronic condition that developed over a period of time, usually years. This is usually how it comes about, or sometimes it happens after you have a big heart attack. Okay, obviously, if you have a big heart attack and you kill some of your heart, that's not going to help things. Coronary artery disease, valve dysfunction, heart disease, excessive salt and water intake. Yeah, electrolytes can cause this. Hypertension, thyrotoxicosis, pulmonary embolism, alcohol, drug abuse, and anemia. All of these things can influence congestive heart failure. Let's talk about how and why. We generally divide this up into the left ventricle or the right ventricle. You guys know that the left ventricle is the bigger, stronger ventricle. It is essentially the moneymaker in the heart. All right. It's the one that needs to pump against systemic resistance to overcome all that pressure in the aorta to send blood up to your brain so that you can hear what I'm saying right now. It's doing that flawlessly. It's been doing that since the day you were born, flawlessly. Well, hopefully flawlessly. I don't know how all of your guys' hearts are, but for most of us, this works really well. This heart, this incredibly amazing pump, will work pretty much without any problems for about 70 to 80 years, maybe without any real routine maintenance, right? You might need to start taking some medications and change your diet, but that's not really maintenance. That's just like changing. That's like if you took your car into the gas station, you never once took it into the mechanic, you just occasionally switched from regular fuel to premium, and that's all it really needed. Our bodies are extremely efficient. Now, there's two different types here, backward and forward failure. So anywhere blood starts having resistance, blood's going to back up behind that and increase in pressure. That's the important concept between the different types of congestive heart failure. So left-sided failure occurs when the left ventricle is unable to pump effectively. Essentially, afterload is too high or preload is too low, and it's not going to be pumping effectively against all that resistance. It's still sending blood out. It's just not going to be able to send all of its blood out. So pressure is going to build up everywhere in there and behind it. Your left ventricle is going to get stronger as a result. It's getting buff. Finally, your left ventricle has been hitting the gym. Unfortunately, like we said before, your left ventricle does not want to get buff. And you don't want your left ventricle to get buff. You want it to be strong, but you don't want it to get buff and bigger. That's the problem. So when blood backs up in your left ventricle, it's then going to back up into the left atrium, and then it's going to back up into the pulmonary veins. Remember, the veins return from the heart. They're returning oxygenated blood from the pulmonary circuit. So veins mean they're going towards the heart. Arteries mean they're going away from the heart. And then once it backs up in the pulmonary veins, it's going to back up into the pulmonary capillaries. And when that happens, potentially it might start leaking through that tiny, tiny little 1-cell thick membrane between the alveoli and the capillary membranes. And all of a sudden, plasma is going to get pushed up through there. The red blood cells, they're too big. White blood cells, they're too big. Platelets, they're too big. The only thing that's going to get pushed up through osmosis and oncotic pressure is the plasma, the water part of your blood. Now, why does that turn kind of pinkish when we're coughing up, right? We talk about a pink, frothy sputum. That's because inside the plasma are a bunch of broken down red blood cells. Your red blood cells are not all these perfect little like red, like donuts sort of looking things that are all like beautiful and smooth. A lot of them are really beat up. Remember that 2 million of them are dying every second and 2 million of them are being created every second. So a lot of them are just beat up and they're broken down. They've been in your system for like 3.5 months. They're barely transporting oxygen anymore. They're pretty much worthless. Parts of them are even chipping off and falling away. That's what turns your sputum, or sorry, the plasma pink in your lungs, is little broken down red blood cells. The problem with this is now you've got plasma sitting in your alveolar sacs. That means that the air will not reach them, including the oxygen in the air. So now those alveolar sacs are not participating in gas exchange. All right, so remember, all the surface area of all your alveoli would cover, if you were to spread them out, they would cover a tennis court. We're amazingly efficient use of space in there. But if some of that is wet, then nothing's going to be useful in it. So all of these will contribute to increased preload, which will weaken the left ventricle over time. So it's stretching too much, and this is going to weaken it. Compensatory effects can be tachycardia, vasoconstriction, and increased afterload. Peripheral vascular resistance is what PVR is. Left ventricle is unable to effectively pump against the afterload. Increased PVR leads to decreased preload because blood's not coming around to fill it now, which causes decreased stroke volume. So that 70 milliliters of blood you're squeezing out in a healthy heart, down to maybe 50, maybe 40. Left ventricle is unable to eject all the blood during each contraction, which backs up into the left atrium, which will then back up into the pulmonary veins, which will back up into the pulmonary circuit. This causes back pressure. It's going to push things out. Now, in right-sided failure, the right ventricle is unable to pump adequately to the lungs, which causes backup of fluid into the body. Now, what's interesting about this is your right ventricle is not the same as your left ventricle. For one, your right ventricle is not strong because it doesn't have to pump against resistance. Your left ventricle has to overcome the pressure in the aorta and the peripheral vascular resistance. Your right ventricle does not normally have to pump against a whole bunch of pressure. Your lungs are full of blood. Your lungs are not like balloons filled with air. Your lungs are soaking wet sponges, but the air is floating up next to those sponges and getting that blood oxygenated. There's lots of blood in your lungs at any time. It's normally not under any resistance, but it can happen. Does anybody remember the name of what we call right-sided heart failure? We don't just call it right-sided heart failure. It's got another name. It's got 2 words. First word is core, C-O-R. Anybody remember what the second word is? Core blank. Cor pulmonale. There's actually an E at the end there, but yes, cor pulmonale. That's right-sided heart failure. Yeah, there you go. So anyways, that's going to be slightly different because now blood's not going to be backing up into the lungs. So we're going to expect clear lung sounds, but it's going to be backing up into the body. And gravity is going to want to pull that down, meaning that we're probably going to see pedal edema, right? Your feet start swelling up. Probably going to increase, have some varicose veins, things like that. By the way, varicose veins, let me just briefly talk about what causes varicose veins, because this is kind of an interesting subject. I was talking earlier about blood goes, and we know it goes from the heart to the aorta, it goes to arteries, and then it goes to smaller arterioles, and then it goes to capillary beds where perfusion happens. Then it goes to the small veins, venules, then it goes to bigger veins, it goes back to the heart. But does blood only go through one capillary bed before it returns to the heart? How many capillary beds do you think blood goes through before it returns to the heart? Like 1,000? A million? I mean, I told you guys that all of your vasculature laid end to end would cover the earth 2.5 times. So there's tons of it in there. How many capillary beds does it go through before it needs to be returned to the heart? Anybody have a guess? 10 million? 20 million? One single capillary bed? You guys might be surprised by the answer. The answer is one, but not always one. There are 3 instances where blood will go through 2 capillary beds before returning to the heart. One of those is in your brain. Goes from blood fills in it perfuses in your brain, and then it goes through another capillary bed in your hypothalamus in order to transfer the hormones. All right, so that's important. Another one, I can't remember where it is. It's not going to come up again. But the third one happens in the portal veins. You guys remember here learning about portal hypertension back in the day and esophageal varices? What's going on with all that? Well, here's what's going on with all that. Remember I told you that you take pills and pills are absorbed in your stomach? Nutrients from your food are absorbed in your small intestines, but pills, a lot of them get absorbed in your stomach. So capillary beds are in your stomach, and they oxygenate your stomach because it's a muscle. It needs oxygen just like everything else. And then they absorb the medication into that plasma, and then they take it directly to the liver because it needs to be transferred. Remember, the inside of your body is technically the outside of your body, and your stomach is outside of your body. So it needs to go through your liver to get processed first. So that's anytime 2 capillary beds are connected, they're connected by portal veins. Now, when the pressure builds up in your liver due to hepatitis or chronic alcoholism or something that's causing inflammation and increased pressure in the liver, those portal veins are going to start to get backed up, and they're actually going to start to cause varicose veins. These are the same varicose veins that form in pregnant women because they're having trouble returning blood flow to their heart. So the vasculature, those veins normally are returning blood up. They're undercoming resistance, and so they start backing up and forming these new venous passageways called varicose veins. In your legs, these are not so much of a consideration, right? They don't look good, but they're not bad for you. But this can happen in your esophagus because as blood passes from your stomach to the liver, it passes behind the esophagus. And so if pressure builds up, it's going to start intertwining with the vasculature of the esophagus. And now if you vomit and it ruptures that, you're not just vomiting a little ruptured like blood clot, you have just ruptured the blood flow that supplies your liver. Remember, I just told you that's 1,200 milliliters per minute. That is going to become a major airway concern very quickly. I have only seen esophageal varices once before in my career, and let me tell you, they were just vomiting up blood, copious amounts of blood, more blood than you would ever expect to come out of someone's mouth. It's amazing. All right. Now, the biggest cause of right-sided heart failure is usually left-sided heart failure. As things continue to get backed up and backed up and backed up, eventually we're going to start to affect the right ventricle as well. Now we've got both sides of the heart affected. Ain't good. So you can see the difference between a normal heart and an unhealthy congested heart. It's bigger, it's more muscular, but that's not a good thing because actually it's not stronger, it's weaker because of this. How do we treat this? There's unfortunately not a whole lot we can do to treat the congestive heart failure. That's kind of on the patient. What we can do is we can try to make it more comfortable for the patient. So it depends on which side of their heart is failing. Now, for most 911 concerns, it's going to be left-sided heart failure because now it's backing up in the lungs. Now we've got not only cardiac effects, but breathing effects as well. So we want to give them oxygenation, and CPAP is going to help as well. Now, How does CPAP help? Let's break it down because here's how it works. So you've got plasma flooding into the lungs. We call this an acute pulmonary edema. All right. Fluid is now building up in there because the left side of the heart is failing. And now we've got severe respiratory distress. Well, we want to treat this in a number of ways. One is if we increase the vasculature, well, here's ultimately what we want to do is we want to decrease their blood pressure. I know that might seem counterintuitive, but bear with me on this. If we decrease blood pressure, their body's natural defensive mechanisms are going to kick in, AKA the sympathetic nervous system. When the sympathetic nervous system kicks in, it's going to release all the chemicals that are going to help this process get better. So if we can make their blood pressure lower, we can kick in things that are going to help them out. And here's how. When your blood pressure lowers, you start releasing chemicals that pull things into the vasculature from the interstitial space. That means anything outside of the cells and outside of the vasculature. So in our muscles or in our lungs or in our brain. So if we start lowering the blood pressure, your body's going to start reabsorbing fluid from outside of it, and it's going to pull that stuff back with it, including it's going to pull stuff back in from the pulmonary circuit. Now, we have a couple ways of doing this, right? A couple ways of dropping someone's blood pressure to have this effect. CPAP is one of them. A BVM would work just as well. And here's how that works. You can think of it simplistically as if I put a BVM over someone and I start squeezing air into them, I can use the air to force that plasma in their alveoli back into the vasculature where it should be. Realistically, physiologically, that's not really what's happening. That's the same effect, but here's what's actually happening. When we increase intrathoracic pressure through positive airway pressure, we decrease the amount of space the heart can expand. Are you guys with me so far? If the heart can't expand fully, that means we're decreasing its preload, okay? So with more pressure means the heart can't expand, means the heart's not getting full stroke volume. So blood pressure is going to drop. And then once that blood pressure drops, boom, everything else starts kicking in and we start pulling that fluid from the vasculature and from the alveolar space, back into the vasculature. We also want to administer nitro because this is also going to decrease blood pressure, right? We don't give nitro because it makes we give nitro in the heart effects because it'll make their coronary arteries bigger, hopefully fixing that clot that they've got going on, or at least moving the clot to a less serious area where it's going to be damaging less of the heart, right? If we can move it to a smaller arteriole or a capillary bed, it's going to be affecting less of the heart. And that's ultimately what we want, right? In fact, if we can get it to a capillary bed, we're golden because capillary beds are branch out and we'd be fine. But we give nitro for this because we're trying to increase the vasculature so we pull the stuff out of their lungs. That's what we're trying to do there. Because if we don't do anything, we're going to go to cardiogenic shock, which is circulatory failure caused by pump failure, aka heart failure. Now, heart failure is an interesting concept to talk about. It just means that the heart's not doing the one thing it's supposed to do, which is pump. We also call this, this can take many different forms, right? It just means the heart's not effective enough. So if you have a heart attack and you're not perfusing well enough, that's heart failure. If your heart stops and arrests, that's heart failure. If your heart is no longer overcome systemic resistance, that's heart failure. It's lots of different processes. Talked about some of the things that your body will do. How do we treat someone with cardiogenic shock? The same thing, guys. We need to monitor their ABCs, positive pressure ventilation. CPAP's great if they're conscious, BVM if they're not. Either way, we're going to increase or decrease their blood pressure and increase them pulling that fluid out of their lungs. Let's go over ACLS. As you guys know, ACLS stands for Advanced Cardiac Life Saving. ACLS is a requirement for paramedics to have, even if your department does not follow ACLS. AHA, the American Heart Association, defines ACLS algorithms. These are, without a doubt, the best things for dealing with patients having any sort of cardiac problems. I'm not going to spend a whole lot of time talking about ACLS stuff because a lot of it can be looked at on the ACLS website, or you can download some cards. I have some flashcards with all the ACLS guidelines on them. I can look at them if I ever need to get that information. So I'm going to talk about the main ways that we treat everything that might come up. And then we're going to get on to some EKGs, and that'll be fun. All right. So sinus bradycardia, second and third degree heart blocks. Both of these are going to cause bradycardia, by the way. So sinus bradycardia, we'll monitor the ABCs. Now we can also give atropine, or we could possibly do transcutaneous pacing. It probably depends on the severity of the bradycardia. If we've got a narrow complex bradycardia, so the QRSs are nice and narrow, probably want to go with atropine. Now, if it's really wide complex or they're very unstable, we might go directly to transcutaneous pacing. And dopamine will help to act as a vasopressor to get their pressures up if it's refractory to fluid boluses. Possibly, we could also go with an epidrip for similar effects. Now, kind of similar with second and third degree heart blocks, except we're not going to go to the atropine. Atropine is only if we're in a sinus rhythm. Remember, if we're in a second or third degree heart block, the electrical conduction is blocked somewhere along the way. This is still coming from the sinoatrial node. So then remember, that's the primary pacemaker of the heart. Here's an interesting thing about the heart, you guys. The heart, as you guys may remember, has an effect called automaticity, meaning that the heart does not need any intervention from the brain in order to beat. The heart will keep beating 60 to 100 times a minute for its entire life cycle. No problemo. In fact, the brain cannot tell the heart to beat or not beat. The brain can only tell the heart to speed up or slow down. That's it. Everything else is handled by your sinoatrial node, generating those electrical impulses in the same way that every cell generates impulses through that action potential. The sodium potassium pump, pumping stuff one way or the other until boom, it has a reaction and it sends this electrical current down your heart that makes everything contract. This is a sinus rhythm. Second and third degree heart blocks are not sinus in nature. So atropine is going to have no effects. You know, what's also interesting about this is the sinoatrial node, those pathways are not fully developed until we hit maybe puberty, maybe a little early, so the 6 to 12 ages. It depends on the person. So for infants, atropine is not going to work. It's not. The only thing we can do for an infant or a ped in sinus bradycardia would be go straight to epi, and probably not pacing, but epi. All right. So it's going to depend on the case. We can pace patients. We can pace kids sometimes. All right. Now, what about sinus tach, atrial fib or flutter with rapid ventricular response? So this is when they have AFib or aflutter, but it's at a way faster rate. Okay. 120 to 140, that's AFib with RVR. Or any narrow complex tachycardia. So we're not quite an SVT, but we're in a very unstable tachycardia. Now, if they're stable, vagal maneuvers, right? The vagus nerve is innervated, is one of the cranial nerves. It's coming out of your spinal cord and it innervates your heart. We can influence this, right? If you bear down, almost like you're going to the bathroom, number 2, if you're trying to push, that's called bearing down. That can stimulate the vagal nerve and will lower your heart rate. I'm sure you guys have experienced trying to blow up a bunch of balloons for a child's birthday party or an adult's birthday party, or I don't know, just because you wanted to blow up a bunch of balloons. What's happening when you blow up those balloons is you're increasing resistance and you're dropping blood pressure and you're affecting the vagus nerve, so your heart rate's going down. That's why you start to feel lightheaded when you're blowing up balloons. It's kind of the same thing we're trying to do when we give a patient a syringe and we try to tell them to blow the top out of the syringe. I've seen patients blow so hard that they actually do blow the syringe all the way out. I've never seen one blow it out. That would be crazy. But I've seen them blow the syringe all the way, like extend it, and it doesn't affect their heart rate at all. Vagal maneuvers may or may not work. They're not going to work for kids, okay? Because remember, that passageway is not effective yet. That doesn't mean that kids can't raise and lower their heart rates. Obviously, they do all the time. Kids are running little maniacs, but we're going to have trouble exerting manual control over it. Now, calcium channel blockers and beta blockers might also be administered. Cardioversion, remember that's different than defibrillation because most cardioversion is something called synchronized cardioversion, meaning that we need to shock them during a very specific part of the EKG. I don't remember exactly where in the EKG it is. I think it's right during the QRS complex, somewhere right before it, but we're going to shock them right before it at just the right time. Now, for normal defibrillation, it's not synchronized. It's just defibrillate, defibrillate, defibrillate. Cardioversion almost always will be synchronized to their heart rate. And finally, amiodarone is just an antidysrhythmic. And if they are stable, then just the vagal maneuvers and potentially adenosine for fast heart rates. Adenosine is usually saved for SVT. All right. Stable wide complex tachycardia, monomorphic, also known as, it's just a wide complex tachycardia. This is getting very close to ventricular tachycardia, though. Amiodarone, again, is the one that's recommended here, as well as cardioversion. These numbers will vary. Treatment of unstable wide complex tachycardia, some more. Anyways, may also attempt amio fluid bolus as an antidysrhythmic. Pulseless wide complex tachycardia. Well, pulseless is the key word in this, right? The rest of this is pulseless VFib or pulseless wide complex. This is pulseless VTAC or VFib. CPR. Pulseless is the key word there. You gave adenosine yesterday. I've given adenosine probably twice in my career, not very frequently. Normally, when I have a patient in SVT, it's because they've taken something, right? It's not because they usually have like a condition that's causing them to go into SVT. I've seen people convert all sorts of things. I've seen adenosine convert people. I have also seen vagal maneuvers convert people. I've seen, and I'm starting an IV convert people. I've started doing something, if I can get permission, or I started doing something before I quit in the field with captains, if they would allow me, I'd try to say, hey, before we give the adenosine, can I just give a 20 mil fluid bolus to test the patency of the line? And they say, okay, great. And I'll just, boom, push a 20 mil fluid bolus, the same as you would with adenosine. Like after you push the adenosine, you give that fluid bolus to push it to the heart quicker. Let me tell you, just the fluid bolus, 20 mil fluid bolus, rapid, cool liquid to the heart, that's converted people. And if you can convert someone without giving adenosine, give yourself a pat on the back because adenosine is also not good for you. Anything that literally stops your heart for 10 to 15 seconds is not good for you, right? Also, it's terrifying. Chad, I'm sure your experience with this the other day, it was similar to every time I've given adenosine, is you're kind of puckered up, that you see him go at asystole, and you're just like, okay, any second now, any second now, any second now, any second now. There's something, and we're back. Okay. But let me tell you, it doesn't feel like 10 seconds in real life. It feels like about a minute and a half. Same thing with this. Defibrillation, EKG. All right, so begin compressions, then defibrillate. Higher dosages than what we had before. IV, access. Remember I talked about the 4 things we need? Compressions, electricity, access, and oxygenation, airway control. We're also given 1 milligram of the cardiac epi, the 1 to 10,000 concentration. And then if they're refractory to those, we can give amiodarone or lidocaine, depending on whatever you have available. Usually it's going to be amiodarone because lidocaine is weight-based, whereas amiodarone is just a straight dosage. So that's hella easier, right? So let's go with that if we can. All right. Wide complex polymorphic tachycardia. This is something called torsades. This is a very interesting presentation, and we can be treated with a lot of stuff. Ideally, mag sulfate is what we would use to treat this. I've seen one patient in torsades, and I was in San Diego where we do not have mag sulfate as a drug. So what do we do in that case? You shock them. There's torsades. So torsades in French, by the way, the full name is torsade de poing. I don't know. It's French. It literally means twisting of the points. That's what torsades means, twisting. So see how this is kind of like an M, it's sharp at the bottom, and now here it's like a W, it's sharp at the top. That's what we mean by twisting of the points. Literally think of the magnetic poles of the earth. Imagine if they just started switching back and forth every couple seconds. That would cause a lot of chaos, right? And that's essentially what's happening in the heart. Electromagnetism is a very complex feature. And by the way, it's one of the 4 fundamental physical laws of our universe. We don't understand how physics works, or we understand how physics works, but we don't understand why physics works the way it does. What we can truly measure is that there are 4 things in our universe that affect all of physics. One of them is electromagnetism. Electricity and magnetism go hand in hand. You cannot really have one without having the other. Gravity is another one. So gravity, electromagnetism, those make sense to us. The other 2 forces that combine, that control all of physics in the universe are the strong and weak nuclear forces. And I'm not talking about nuclear reactors. I'm talking about the interactions between atoms. That's what gives off radiation. Everything is radioactive. You and I are radioactive. Bananas are radioactive. Water is a little bit radioactive. Everything has slight levels of radiation. Radiation in and of itself is not dangerous to us. It's only when you get massive dosages of radiation that the problem occurs. And we're going to talk about that later. Don't you worry. All right. Finally, we've got pulseless electrical activity, PEA. Remember I told you that the heart is automaticity? It does not need innervation from anything else to beat. And we know this because literally if you chopped off your head, your heart would still be beating. It would keep beating for sometimes as long as an hour later. It just keeps going. It keeps going. It's still wanting to do its thing. We call this pulseless electrical activity. I've shown up with people that are definitely not alive, but their heart is still performing these things because the cells that make up your heart, they don't know that the cells that make up your body are dead because that's not how cells work. Cells are independent. They communicate to each other, the ones that are in their immediate vicinity. But the cells in your heart are not really communicating with the cells in your brain. And if they aren't, it doesn't matter anymore. It's kind of like you call up your best friend and then you don't talk to him for 3 months. And then you call him up again, you find out he's been headless for the last 2.5 months. And you're like, oh shit. Well, I guess I will go ahead and stop what I'm doing then. That's kind of what will go on. I've seen people be in PEA up to an hour after they were dead. But that kind of raises an interesting point. When do we die? And that's an interesting kind of question to think about. I know as an EMS provider, if you guys have worked in the field, and even if you haven't, I'm sure you've dealt with death in some capacity or another. Maybe it's just a pet you've had, or maybe a grandparent or something like that. Death is a very complex idea because, like I said, we're made up of 37 trillion cells. And even if you chopped my head off, most of those cells would still be alive and doing just fine. And they're going to keep living for a long time. But the cells that come together to form me are no longer functioning as a human being. So my biological creature is dead, but the biological structures of my cells are still doing just fine until they stop getting oxygen, and then they're going to start to swell up and die, and then it's going to be a whole thing. So determining when death actually occurs is kind of an interesting concept. I've pronounced, I don't even know how many people in my career, probably like 30 or 40 people. And some of them were a lot more dead than others. Let's put it that way. It's kind of an interesting concept. The fastest I ever saw anyone die was a AAA rupture, an abdominal aortic aneurysm rupture. That is by far and away the fastest I have ever seen anyone die. I don't know if you guys have ever seen a AAA rupture, but it's amazing. It's quick. I went from chatting with the guy, and then he starts telling me, oh, my chest. Oh, it hurts. And he was asking me for nitro. And I was like, dude, your pressure is like too low. This was a GI bleed, by the way. He was like, 85 over 40 or something like that. I was like, your pressure's too low. I already had I had 16 gauge. I was giving him fluids already. I'm transferring. I'm like, your pressure's too low for nitro. Sorry, man. He's like, oh, it's bad. And then he stopped talking. And that was the last I ever heard from that guy. 3 minutes later, when we pulled into the hospital and I was cranking on his chest, he was ice cold. He looked as dead as anyone I've ever seen. That is the fastest I've ever seen anyone go from talking to me completely alert and oriented to deader than a doornail, to use a tired expression. All right, now let's talk about some vascular problems. Here's one called cardiac tamponade. Impaired diastolic filling of the heart caused by increased interpericardial pressure and volume. So let's talk real briefly about the pericardium. The pericardium is that fluid-filled sac that surrounds the heart. It's filled with about 25 to 30 milliliters of a straw-colored fluid called pericardial fluid. It's very similar to the pleural sacs that surround your lungs. Why do we have these sacs surrounding our lungs and heart? That's because your heart and lungs change shape. They get bigger and smaller all day long. Anything that's changing shape is causing friction. And anytime friction happens, heat builds up. Go ahead and rub your hands together for a minute and then tell me they're not very warm. Friction causes heat energy. Now, if we didn't have nice lubricated sacs holding our heart and lungs, they would get so inflamed and so heated up with all that friction that they would burn. It would hurt every time we take a breath or every time our heart beats. That's not good. That's not ideal. Now, this can happen, right? We call this pleurisy when it happens in the lungs. When that lubrication breaks down, it hurts to breathe in and out every single time. When we get too much fluid building up in the pericardium, we call that cardiac tamponade. Now, what's this going to do to the heart? It's going to decrease the amount of space that the heart has to get bigger. All right. Think of it this way. You've got the heart. It's got a very thin layer around it of lubrication. Now, all of a sudden, you've got more stuff in there. The heart's not going to be able to expand as much. So you're reducing preload. So we're going to expect to see certain things going along with that, including jugular vein distension. The other two signs, by the way, guys, you might remember Beck's triad and Cushing's triad. Do you remember learning about that way back in maybe even at EMT school? These are two different things to look for. Cushing's triad is for traumatic brain injuries. I'll go over that when we get to the neurology section. Beck's triad, that one is for cardiac tamponade. And we're going to see muffled heart tone. So if you put your stethoscope on the heart and they're listening to it, they're going to be muffled because there's a layer of fluid in there. We're also going to see jugular vein distension. This is kind of the same thing as congestive heart failure, only very rapid. Jugular vein distension. And finally, we're going to see something happen to the blood pressure. In Cushing's triad, we see something called widening pulse pressure, meaning that the systolic and the diastolic start getting further and further away from each other. In tamponade, we're going to see the diastolic and systolic numbers getting closer together, okay? And why is that? It's because the heart's not able to expand so much, so every contraction is going to be less effective. That's the top number, systolic. And the diastolic's going to have to raise in order to compensate for that. So that's why they tend to get closer and closer together. That's what's called a narrowing of the pulse pressures. I'm sure you guys remember learning about that way back in the day. Here's on X-ray what it looks like. There's the heart. There's the pericardium. Look how much extra fluid has been built up in there. That's not good. There's nothing we can really do for this. Sometimes you can do a procedure called a pericardiocentesis, which literally means sticking a needle into the heart sac right there and then draining the fluid out manually. That works really, really well. But obviously there's a lot of danger associated with that. Finally, we've got aortic aneurysms. I told you before that the aorta is under the highest amount of pressure. A huge amount of blood is going through your aorta. It's very strong. It lasts normally your whole life and longer, honestly. Everything else in your body is going to go out before that. But it can weaken. It can form an aneurysm, which is when it balloons out and it gets weaker. It's kind of like a bleb in your lungs, if you guys remember those. This can rupture, and this will cause significant bleeding. How do we repair it? We need to put more strengthening things around it, kind of like a stent on the outside. We can also dissect the abdominal aorta, and this is the one that I saw on the guy. It ruptured down in here. This is also under high pressure because it has to pump blood down to the lower extremities. There's a AAA formation right in there. All right. Hypertensive emergencies. This is when all of a sudden blood pressure jumps up rapidly. Normally we're looking at diastolic rather than systolic. Okay. Diastolic over 100 is considered hypertensive. When I first started working in this field, I was very much paying attention to the systolic numbers and not so much the diastolic numbers. When I became a better paramedic, I started paying more and more attention to the diastolic numbers. That's ultimately what's going to change the patient's presentation the most. All right. Let's talk about some hardware that can help your heart out. For one, pacemakers. The big AEDs we have, those are external defibrillators. This is an internally implanted defibrillation device. So this is a inside AED or a pacemaker. Demand pacemakers only fire when needed. We have ventricular assist pacemakers and atrial assist pacemakers, depending on where you need more innervation. Most of them are ventricular assist, and they're demand only, meaning that they'll shock you if you need it. These things last pretty good. They last 5 to 7 years before the battery needs to be replaced. But this is a mechanical device, so it can fail. That can be a problem. All right. We used to place pacemakers on the upper right side of the chest because of the directionality of electromagnetism within the heart. Now we know that in case this patient ever needs to be defibrillated, that's not a good idea. So now we place them on the left side of the chest. You should probably never meet a patient with a right-sided pacemaker because probably all of them are dead at this point. What are the problems with pacemakers? Well, the same things as everything else. They can malfunction. They need to be replaced. The batteries can die out. And also, they can become dislodged. This is the bump. This can also be affected by heavy magnets next to them. MRIs can affect pacemakers. There's lots of considerations that we need to be aware of. In fact, some pacemakers are even influenced by magnets over them. Specific electromagnetic frequencies over the pacemakers can change the way that they're firing. A runaway pacemaker is when it just starts firing on its own too. Just starts beating over 300 beats a minute. This is also known as a non-perfusing rhythm, right? This is the same as extreme VTAC. Or the sensing device can failure, or the end becomes dislodged. It's just not working. It's firing too much. What I've seen a lot in San Diego is we have a large homeless population here in San Diego. And people will generally not replace them. They'll have had their pacemakers for 10 years and they still work because they're well designed, but then all of a sudden they'll start firing. And the problem is they need to get those pacemakers replaced. And some of them just don't have the ability to do that. All right, scenario 1. By the way, I don't necessarily have the answers for these ones, so we can all work through them together. We're going to try to look at these heart rates and see what they look like to us. So this first one we got 79-year-old male choking on a piece of meat, which was removed. Pressure's good. Respiration's good. Heart rate is as follows. So first thing we want to look at is, what's your general impression of this? Looks slow, but it also looks like it's maybe speeding up. Interesting to see what's causing this. Now we are seeing, looks like an absence of P waves, but maybe we are seeing some right here. It's hard to say for sure. To me, it almost looks like a junctional rhythm in here. And maybe going back into a sinus rhythm. Again, I don't have a name for it, but let's call this a junctional rhythm. I think that's common. Now, what's causing it? He was choking, so probably vagal down. Yeah, vagal down from choking would be my guess too. So that's would be my guess as to what caused this one, but that's an interesting one. Now let's look at number 2 here. 65-year-old male, complaining of chest pain, 8 out of 10 on the pain scale. What are we looking at here? One of the first things I like to look at is it regular or not? Generally, this looks fairly regular, except for this nonsense. Something's going on in here. It looks like we got a rate of about 120. Hold on. Yeah, a little fast. Looks to me like we're definitely also seeing some ST elevation as well. But looks like sinus rhythm. P, QRS, ST elevation. P, QRS, ST elevation. And something's going on here. To me, this looks like a premature atrial contraction or maybe a premature ventricular contraction. But it looks like it's the same morphology. So I would say that's a PAC right there. Might be a STEMI. We can't really call it a STEMI because we don't have multiple leads to look at. Well, what we can say is that we've got ST elevation. Because remember, STEMI means that it's a myocardial infarction. We don't necessarily know that that's true. What we do see is ST elevation, though. So yeah, generally that's true. All right, number 3. Well, that does not look good. But when we break it down, what are we looking at here? PQRS. Well, it looks like we got PQRS, PQRS, P, nothing, PQRS. What do we call this when we're seeing P waves and no associated QRS complexes? A heart block. Does anybody remember what kind of heart block? Third degree means that the QRSs and the Ps are not related at all, right? The QRSs are firing and the Ps are firing, but they're not related. It's a second degree, but there are 2 types of second degree heart blocks, remember? There's the Winky-Bach walk, which is where the P wave gets further and further and further from the QRS. That's type 1. And then there's type 2, where the P just drops the QRS. And we've just got PQRS and drops. This looks like a second degree type 2 heart block to me with wider QRS complexes. This guy is probably not going to be doing too good. But yeah, I've seen PQRS, PQRS. This is normal. Well, not normal, but it's more regular conduction. And then we've got dropped QRSs. This looks like a second degree heart block to me. Let's look at this bad boy here. This patient's unconscious, 60 years old, unknown history. So first of all, is this a sinus rhythm? It looks like we've got a long pause here. The rest of it looks like, maybe bradycardic. What are we seeing? Remember, you guys might remember the rule of the box rule to count out. Every box you can count out. 1 box would be 300 beats a minute. 2 boxes, 150. 3 boxes, 100. 4 boxes, 75. So this looks like it's within the 60 to 100 range. Other than this, so what do we call normal sinus rhythm with a pause? We call that a sinus pause, yeah, or a sinus arrest. It's just an extended period without any heartbeats because the sinoatrial node should be firing 60 to 100 times a minute, and it's not. This is this pause and the sinoatrial firing. So it's a sinus pause. All right, here's one that's a little easier. 76-year-old woman, back pain. Medical history includes an MI 2 years ago. Well, I think it might include an MI now too, if we're not careful. But what are we seeing in the middle of here? What is this thing? What do we call that structure? That weird formation? Right, a premature ventricular contraction. It's different than a PAC because a PAC would still have a P wave, right? This one doesn't. This is just going way into this weird morphology. Other than that, it looks like it's also after a slightly longer pause. See, these all look nice and regular. They're like boom, 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 boom. But look at here. We've got boom, boom, and then we've got, it looks like a slightly elongated pause, and then this weird nonsense. So I would guess that also we're seeing some ST depression The ST wave is below here. That's indicative of ischemia, meaning that her heart's not getting enough oxygen. Also, PVCs are indicative of ischemia. We've all probably had a couple PVCs in our lives. In fact, PVC is not uncommon. If you drink an energy drink, you're very likely to throw them out. You and I, as perfectly healthy individuals, are probably throwing out 1 or 2 a month without realizing it. Here's one. Male in his 40s, electrocution. He's pulseless and apneic. Well, he's pulseless, apneic, so we know what we're doing. What do we call this rhythm, though? V-fib. Ventricular fibrillation. I like to think of it as the heart is seizing up. When it's tacking out, it's beating too fast, so the preload is going down. It's not filling with enough blood. At this point, it's just fibrillating. It's just seizing. Fine V-fib is another way you could say it because it's very narrow and it's complex, very, very close to asystole. By the way, that's the next step. Number 7, 83-year-old male, cool, pale, diaphoretic, doesn't feel too good. Well, probably because your heart's not beating fast enough. Again, normally we expect a P wave. That's what indicates that it's sinus, meaning it's firing from the sinoatrial node, which is set up in the atrium. This guy, I'm seeing no P waves. So that tells me that he's got at least a junctional. Now, I don't think that it's an idioventricular rhythm because normally idioventricular are wide complex. Now, it could be ventricular escape, but realistically, this looks like a junctional rhythm to me. And then maybe we're noticing a little bit of weird ST, maybe depression going on there too. So this is, to me, just too slow. It's not going to be perfusing very well. Now, we've got an 8-year-old male drowning victim. Now, this one's interesting because our QRSs, they look nice and even. Are we seeing any P waves? No? I might be seeing some P waves. I think I see one there. Maybe I see one there. Maybe. I'd say that's maybe saying them. That wouldn't, now, that's a complete heart block, also known as what type of heart block? Not second degree type 1, Chad. That would be a Winky-Bach walk. That would mean it's getting further and further, and then we'd see it dropped. This is a 3rd degree heart block. Now, here's the way that we can tell the difference between the heart blocks. In case you guys can't remember, let's go over them real quick. A 1st degree heart block, normal, you see a P, QRS, T. The P is separated by at least one of these boxes. Normally, we expect the P's and the QRSs to be nice and close together. When the P is further out, that's a 1st degree heart block. Now, that's going to be a regular rhythm. I mean, what I mean by that is that the QRSs are going to be regular like this. You can also remember that 3rd degree will also see a regular rhythm. Because remember, a 3rd degree means that we have a complete dissociation from the atrium and the ventricles firing. They're not in conjunction. So the atrium are firing in a normal thing, but the QRSs are also firing. They're just not in conjunction. Why would a drowning 8-year-old be in this? Because, I don't know, because it's a scenario. Realistically, though, it's not unlikely for someone who's been hypoxic for a long time to go into a heart block. That can definitely happen. In fact, when someone is drowned, and it might be a cold water drowning, expect them to become very bradycardic, and sometimes that can be caused by heart blocks. Or it's possible that the heart block caused him to drown. That might be another possibility. It don't necessarily need to be mutually exclusive or mutually related. So, number nine. The rhythm strip is from a patient who was found apneic and pulseless. Well, right there, they're pulseless. So what do we call this bad boy? P-E-A. Excellent. That was a nice, easy one. Oh, yeah. What is this one? You have to spell it in French or you don't get credit. Toad's a fib. Torsades a fib. Torsades de point. That's what you meant to say, Nathan, I'm sure. Yeah, we notice the twisting of the points. This is a beautiful way to describe it because it's literally just a twisting of the points. All right, now we're going to do some faster recognition. So the idea behind these is to just do, within about 6 to 10 seconds, recognize these strips. Or I guess these are 10-second strip recognitions. Now we're going to take a little bit longer because I'm going to go over this stuff with you. Some of you guys may not have done any cardiology in a while, and it might be helpful to go over them a little more slowly. And some of you guys, it's going to be really easy for you. Just think of it as review. And by the way, I do have all the answers for these guys. So, numero uno. What do we call this rhythm right here? It's extremely slow, wide complex, no P waves. Idioventricular. Ventricular, obviously, the ventricles are starting the beats. So remember, your sinoatrial node fires at a rate of 60 to 100. It then goes down through the passageways into the AV node, the atrioventricular node. That connects the atrium with the ventricles. That makes sense? That one fires at a rate of about 40 to 60. Then it goes down into the right and left bundle branches, and then finally to the Purkinje fibers. Those fire at a rate of about 20 to 40. That's what we're seeing here. This looks like a rate of maybe like 35 or so. Wide complex, meaning that only the ventricles are involved. No P waves, no atrium involved at all. Just the ventricles are squeezing. What about this bad boy here? Yeah, I see a third degree. Again, remember, the P's are even. If you were to space them out, boom, 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 boom. This one's getting lost in there somewhere. Boom, 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 boom. And the QRSs are normal. Boom, boom, boom. But they're not working together. There's a block happening somewhere, probably in the AV portion of the heart, that's blocking, or the bundle of His, which is blocking the atrium from communicating to the ventricles. So they're just doing their own thing independent of each other. All right, number 3. What are we seeing here? Well, it's irregular. Do we see P waves? Yes. Do we see constant P waves? Looks like, yeah. Are they going further away? Not really. Looks like they're just dropping. That would be a second degree type 2, right? So P, QRS, T, P, nothing. P, QRS, T, P, QRS, T, P, nothing. This is a second degree type 2. We're dropping that QRS complex. Number 4. What are we looking at here? So the first thing we want to look at is the rhythm regular? Looks regular, looks good. Junctional is a pretty good guess, Chad. Except because junctional will either see no P waves, or they could be all depressed P waves. That can also be junctional. It doesn't have to necessarily be absent. They can be depressed. But here we're seeing some depressed P waves, and then look at this P wave. That's not depressed. Do you remember what we call this? When the P waves are changing their morphology. This one's a tough one. This one might stretch your brain a little bit because it's not one we see frequently. No, not AFib, because that would be an irregularly irregular rhythm. This one's nice and regular. Plus, AFib usually doesn't have P waves. So what we call this is a wandering atrial pacemaker, a WAP. Think about it. The atrium are obviously, something's going on with the atrium here, right? Because that's what the P wave represents. The P wave represents the atrium firing. The QRS is the ventricles firing, and then the T wave is the ventricles repolarizing. The atrium also have to repolarize, but that's such small electrical conduction that it gets lost within this QRS complex. So we usually don't see it. So this is a wandering atrial pacemaker. If these were all inverted, I'd be happy to say junctional, but it would be an accelerated junctional, right? Because look how fast this is. But since this P wave changes morphology, this is a wandering atrial pacemaker, different than junctional. Close, but different. What about this guy, number 5? That's a pretty interesting sawtooth pattern right there. Yeah, sawtooth pattern, A flutter. The difference between A flutter and A fib is that A fib is irregular. A flutter is very regular. These are very different very different things that are happening. Number 6. What are we seeing here? Number 6. Yeah. Now we're talking about a junctional rhythm. Again, if we could also have junctional if they were all depressed P waves, but normally we see absent P waves. Junctional rhythm, slow, right? We're looking at a rate of about 45, 50, somewhere in there. And absent P waves, meaning that it's starting at the junction of the atrial and the ventricles, so the AV node usually. Number 7, this is a nice simple one there. Yeah, V-fib, that's a pretty simple one there. That one should be pretty quickly recognizable. What about this guy, number 8? A flutter. Any other guesses? I mean, there shouldn't be any other guesses. You're right. That's definitely A flutter. Yeah, same thing, kind of that sawtooth pattern. And also nice and regular. So the atrium are fluttering, meaning they're going it's kind of like atrial tachycardia. That's a way you could think of it. But it's A flutter. Doesn't affect the ventricles, so it's not as damaging. Oh, well, this doesn't look good at all, though. Again, no P waves, so we could potentially think junctional, but what's the difference between junctional and idioventricular? Wide, complex QRS, yeah. By the way, this is the QRS right here. This is ST elevation. That's the ST elevation, and this is the T wave. Wide, that's almost one box wide. Normally, this whole complex should take place within 3 of those little boxes. That's the difference between idioventricular wide versus junctional, which will be nice and narrow. What about numero 10 here? AFib RVR, that looks pretty regular to me. AFib with RVR, we'd expect more pronounced irregularities. PSVT. PSVT would stand for paroxysmal SVT, meaning that we're seeing the patient go in and out of SVT. I'm not seeing that. I'm just seeing SVT. Now, why is this SVT and not sinus tach? Because there's no discernible P waves. We're seeing this T and then boom, and then T boom, then T boom, T boom. All right? Meaning that it's happening, the conduction is happening above the ventricles and we're getting a rapid rate. That's what supra, above the ventricles, supraventricular. Number 11. Number 11. Second type 1 is a great guess. Anybody have a better guess? Because here's the thing, guys. All second-degree heart blocks are going to be irregular QRSs because they're dropping stuff, right? This one, is this an irregular QRS? No. That means if it is a heart block, it's either type 1 or type 3. So anyone want to venture a new guess as to what this might be? Yeah. This is a third-degree heart block. That's tough. But now let's look. P. There's definitely a P in here. Look at this weird QRS. There's a P hidden in there. P, 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 P. Third degree. QRSs are aligned. P's are aligned. This is a third-degree heart block. Now, you were saying second-degree type 1, which would be Winky-Bach walk. And I see that. Boom. Maybe further, but we'd expect it to drop, right? That's the thing, is it gets further and further and further, and then boom, it drops it. There's no QRS. So that's what makes it irregular. This is nice and regular. Number 12. What are we looking at with this guy? What is this guy going on here? Type 1. That's a really good guess. I'm definitely seeing some spacing from this P from that QRS, but I'm also seeing additional Ps. What does that tell me? P, P, QRS. P, P, QRS, P, P. This one might be a little surprising to you guys. This is actually a flutter. This is not a heart block. Because if it was a heart block, it'd be a type 3, right? Because this isn't even. Well, relatively even. And the P's look even. This looks like a type 3 heart block if it was any of them. But it's actually a flutter. The reason we know that is because we're seeing the same conduction between every one of them, right? Boom, 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 there, boom, boom, there, boom, boom, there. This is what we call 2-to-1 conduction. So do you see how it's slightly different? It's easy for us to think third degree. But remember, with third degree, we're seeing no association between the P's and the QRSs. This one, there's definitely some association between the P's and the QRSs. So that's what kind of makes that one a little more confusing. So this is a flutter. Now, number 13, what are we seeing with this guy here? AFib. AFib, is that your final answer? Does anybody have a better answer? Look at the heart rate. How fast is that going? Now, does anyone want to add an addendum onto their AFib guess? Yeah. AFib, rapid ventricular response. AFib should not be this fast. AFib should be wildly all over the place, which this is, but this is a fast one. So AFib is correct, but there's a second part of that answer, which is with the rapid ventricular response. Good job, guys. Number 14. What is going on here? All right. So we got, what are we seeing here? PJCs? I don't know if they're JCs, because if they're junctional, they'd be nice and narrow, right? Those are definitely wide complex, wider than we're seeing otherwise, which would make these what? Not PJCs, but PVCs. Now, is that all there is going on to this story? Or is there a little something else? It's irregular. Irregularly irregular or regularly irregular? There's two things going on here. Let's list them both at once. What's the underlying rhythm, you guys? Here, just look at these last 4 beats. If I just showed you these last 4 beats, that would be pretty obvious AFib. AFib with what? AFib with PVCs. Monomorphic or polymorphic PVCs? Well, that looks like the same to me. Monomorphic. Yeah. Now, what's worse, monomorphic or polymorphic PVCs? I mean, neither is good, but is one worse than the other? Which one will be the worse? Polymorphic would definitely be the worst. Why is that? Well, because if the heart is conducting improperly through the PVCs, it's at least comforting to know that it's conducting improperly the same way over and over again. it's got an aberrant pathway that probably you just need to perform an ablation on and you can solve it. If we're seeing monomorphic PVCs, that means there's at least 2 malfeasant passageways which need to be addressed. That's no bueno. No es bueno. Number 15. You guys are doing really good, by the way. Number 15. Let's see if we can keep that alive. Oh, is this another AFib? Another A flutter? What's going on here? What do we call this bad boy? Third degree. Anybody have any other guesses? Third degree? Are you sure it's not a winky block? Look at how close that one is. Look how far that one is. I'm trying to fool you guys. You were correct. This is a third degree. Boom, 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 boom. Those P's are related. The QRSs are related. Yeah, good job. Third degree. This is getting a lot easier, isn't it? It's nice to get kind of refreshed with these things every once in a while. Oh boy. Well, that one's giving me palpitations just looking at it. Can anybody tell me what the heart rate is that we're looking at here? It might even be faster than 180. Because if we know that 1 box is 300, 2 boxes is 150, and we're a lot closer to 1 than 2, I'd say that we're closer to, yeah, about 230 is a really good guess, I'd say, Phil. Sorry, Surfer Labor. 230 is a really good guess. Yep, 230, 220. I'll give you those. Good job, guys. This is definitely SVT. This person is not going to be happy, and they're not going to be conscious for very long. Number 17. What we got in this boy? What are we seeing here? Start thinking about your heart blocks, you guys. Think about those heart blocks and then look at what we're seeing here. We have P waves. We have QRSs, ST elevation, and then we've got P waves. So this is one that's going to be a little difficult. So here's what can make this kind of difficult sometimes, is that for these second degree heart blocks, sometimes they can appear very close to third degree heart blocks. I'm sure a lot of you guys were having trouble just differentiating. Is this a second degree type 2 or is this a third degree? Because I told you already, that's a nice even rhythm. And P, 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 that could be a third degree, right? Except remember, these P's are happening at the same place every time. Boom, 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 boom. So that being said, is this a third degree or a second degree type 2? Yeah, this is a second degree type 2 with ST elevation. Good job, Chad. Are you guys seeing that now? So this is a little confusing because a lot of times second degrees will present irregularly, but not always. Not always, because here we're just dropping a QRS after every P because we're getting, looks like that P's coming too quickly and then we're missing it. And then when the next P fires, boom, we get it again. So this is a heart block, second degree type 2. Now, it should make sense to you guys that second degree type 2 and third degree can sometimes look similar because those blocks are happening almost at the same point in the heart, okay? Third degree is just a little bit lower than the second degree type 2. So that's why that happens. Now, what about this guy, number 18? What are we seeing here? I'll give you a hint. What you guys are looking for is what's happening over time. SVT conversion to sinus. Yeah, I can agree with that. That definitely looks like SVT. Look at count the boxes. We know that this is somewhere one box 300. It was about 200 so heart rate, and then sinus arrest, and then looks like a more normal heart rate. How fast is that? 300, 150. Still tachycardic. So it's going from an SVT to a sinus tach. And we can see sinus because we can see P waves, and T waves. P, T, QRS, P, T, QRS, P, T, QRS. It's just fast. Yep. Now, we could maybe say that this might not be a conversion. This might be PSVT, paroxysmal SVT, meaning they're going in and out of SVT. But normally, we don't see this sinus pause. To me, that indicates maybe adenosine, although we would not expect this short of a pause with adenosine. So yeah, SVT converting to normal sinus. What about now? What is this guy here? Is this guy regular or irregular, or what's going on? What's happening here? Is this a heart block? What's happening? We're seeing P's, QRS's, and T's. That's sinus. It looks like everything's involved here. That's fast, and then it gets slower, and it's getting faster. It's getting slower, faster, slower, faster, and slower. What do we call this? This is sinus in nature, but the rate is irregular. What do we call a sinus irregular rhythm? I'll give you a hint. It's two words, and one of them is sinus, and the other one means not regular rhythm. Too many Red Bulls would probably cause PVCs, honestly, and tachycardia, and maybe even a little bit of ischemia if it was really bad. You guys, what we're seeing here is just called sinus dysrhythmia. Remember? So this is sinus. This is good. This is totally fine. Most of our hearts are beating kind of more like this than they are nice and regular. Here's why that happens, you guys. Remember we were talking about tamponade and when the heart can't beat very effectively? So when you inhale, take a full breath in. It helps. Here, literally, we can all do this right now. Find your pulse on your wrist, and then take a nice deep breath in and hold it. Your pulse should increase slightly. Now breathe all the way out and feel that pulse slow down. Do you guys feel that? What's going on? Well, let's think about interthoracic pressure. When we increase interthoracic pressure, does our heart have as much space to expand? No. So how does our heart compensate in order to maintain blood pressure? It speeds up. Your brain literally was receiving signals that fast, and it sent chemicals into your heart to speed up the heart rate instantaneously, just because you took a deep breath in and then breathed it out. All of us are experiencing slight sinus arrhythmias if our lungs are really efficient, all right? Especially if you're younger. It's very difficult to get a perfectly normal, like 80 beats per minute forever and ever and ever. That doesn't happen unless you've like completely mastered your breath control. A lot of people are going to be in this thing, which is a sinus arrhythmia, as our breath goes in and out. Breathing in, the heart has to beat faster. Breathing out, the heart can slow down. Kind of a fascinating thing that we can all feel ourselves just by taking our pressure, or just by taking our pulse and breathing in and out. Now, number 20. This one is a really interesting one, but in order to get full credit, you have to spell it correctly. I said you have to spell it correctly, Nathan. Yes, it's a second degree type 1, aka a what? No, no, no. There's a name for it. Starts with a W. I'll give you a hint. Starts with a W. The something walk. But you have to type it out or you don't get credit. You're absolutely right, by the way. Yeah. Let's say anyone else want to venture a guess how to spell Winky Bach? If you don't spell it, you don't get credit for this question. Wikibach? Winky Bach? Wikipedia? I like it, guys. It's good. I've literally seen every single spelling of Winky Bach. I think Chad's close to the correct one there. I think he is. But nobody knows how to spell Winky Bach. That is correct. A second degree type 1 heart block is a Winky Bach walk. What does that mean? The P wave is getting further from the QRS, further until it drops. Just drops it entirely and then starts over again. Further, further, expect it to drop it soon afterwards. Good job, guys. 21. What the hell is that? This one's really messed up, right? Regular sinus? Do we call it regular sinus or do we call it something else? I mean, regular works just fine. Regular is a synonym of the word I'm looking for, but we're looking for a different word. Normal sinus rhythm. That's right. Good job, guys. What about this guy? Uh-oh, I think we put two normal sinus rhythms right next to each other. Did we? Or did we? What's going on here? Pay close attention to those P waves. What do we call it when the P waves have different morphology? Yeah, wandering what pacemaker? What, you mean the pacemaker that was implanted by his doctor is like moving around in his chest cavity? Yeah, a wandering atrial pacemaker. Good job, guys. Because it's also potentially possible for someone to have a wandering pacemaker, right? If their pacemaker breaks loose and just starts flopping around in their chest somewhere. But I don't think that'll present like this. I don't know what that would present like. Good job, guys. 23. What is we looking at here now? Be careful. Be real careful. Type 3. Now, I could see maybe type 3. I could see second degree type 2. So which is it? Second degree type 1, I don't see so much. That doesn't look like a Winky Bach walk because look how close they are when they're happening. Now, you guys, think of it this way. Are you expecting, if this is a type 3, do you really expect every single QRS to have a P wave right before it? No. So I'll give you one more guess. It's all right. That's what we're doing this. You guys are doing really excellent on these, by the way. But do you see how paying attention to these slight differences can change one to the other? It definitely looks like a third degree. I definitely see that, especially if you're like, boom, boom. Yeah, oh yeah, third degree, easy, boom. And plus these look regular, but they're not regular, okay? That is a big leap right there. That's a real big leap. Real big. These are dropped beats. Second degree type 2. So again, you see how it's very close to a third degree sometimes. And that's because third degrees and second degree type 2 are, the block is happening at very similar locations in the heart. So that's why they can present so similarly sometimes. This is probably going to go into a third degree real quickly. And by the way, guys, the only time it matters that you can tell the difference between a second degree type 2 and a third degree is when you're being tested on it. In the field, this makes zero difference. You're going to treat both of these exactly the same way. And Most drugs that have contraindications to second-degree heart blocks also have contraindications to third-degree heart blocks. So again, similar presentations, same treatment, but it does matter when you're getting tested on it. What's we seeing here? We already did one of these on the last one, but just for practice, we are seeing twisting of those points. Torsades de points. Yes. Torsades de points. Twisting of those points. Up to down, up to down. By the way, my torsades case that I had, I literally plugged him into the monitor and I looked at it and immediately knew it was torsades because it appeared exactly like this. Literally exactly like this. I'm not kidding. Torsades looks like torsades. You're not going to wonder about it when you see it. You're going to know it immediately. All right, guys, last one. And on this one, give me a full readout. Give me the full name. Don't just say the big thing that pops out to you. Give me the full diagnosis of this rhythm. That might even involve counting the rate to verify things. The full description of what's going on here. Is a sinus in rhythm? Are you guys seeing a sinus rhythm? A flutter with PVCs? I would expect a flutter to be a little more regular conduction of the atrium. This one looks less. I'm seeing P waves, not always P waves, but I'm seeing mostly P waves. AFib? I see a lot of P waves though. I don't know if I agree with AFib. Plus, that's regularly irregular right there. This to me does not say AFib so much. Don't overthink this one too much, guys. A flutter? Again, this doesn't really scream flutter to me. I see, let's see what good one here. P, QRST, P, QRST, P, QRST. Sinus with PVC and PJC? Where are you seeing the PJC? I see two PVCs with the same presentation, two monomorphic PVCs. Where are you seeing a PJC? At the end? This guy? All right. I can see that. Potentially. Yeah. Now that might be also another type of PVC. So we might be seeing polymorphic PVCs, but you're right. That's something going on weird there for sure. This is sinus tach with monomorphic PVCs. Technically, the answer given in the back of the end of the slideshow says sinus tach with unifocal PVCs, but I've never actually noticed that guy before. That's a good eye on there. That could be a PJC. Might be something else entirely. It's not good. Interesting one. This is an interesting one. I'm actually have to do a little more research on that one. But good eye. You guys did really good on those EKGs. So you can see that the answer they give for 25 is sinus tach with unifocal PVCs, which is interesting because I definitely see something weird about that last one as well. So, moral of the story is EKGs can be tough, but if we break them down, they can get a lot more understandable. That's for sure. I'm just going to touch real briefly on this stuff. We're not going to spend a whole lot of time talking about it because I want to get moving through here. We're basically Cardiac lab values, this is when they're testing someone after they've had a potential heart attack, the lab values they're looking for. We talked about blood lab values earlier. These are 3 things they're looking for: creatine kinase, lactate dehydrogenase, and troponins. All right, this is more of a hospital concern than an EMS concern, but these are the things that will show elevated levels when we're having a heart attack. So the first one, creatine kinase. It's released with muscle damage and is divided into damage related to certain, related to certain tissues. Excuse me. It's the first enzyme to elevate after a myocardial infarction. It's present in 90% of all of them. So this is one of the best ways we have to determine whether someone's had a heart attack. It'll peak within 24 hours and it'll go away after 3 to 4 days. Don't worry about the numbers for it. The next one, lactate dehydrogenase. This one also increases in AMIs, but a little slower. And finally, troponin. This is actually the slowest one, but this is the most definite one we have to determine if there was heart damage. Troponins are the fibers that contract in the heart. Very specific to the heart. They're not in your skeletal muscle. It's the most frequently assessed enzyme. This should be less than 0.4 in a normal person. If it's greater than 0.4, an MI is very probable. Now, it doesn't necessarily mean that you're having a heart attack. Can anyone think of an example when someone could have elevated troponin levels when they had not had a heart attack? Someone's heart has been under a lot of work and their heart is some of the muscles in their heart are starting to break down. What's something that you could do that would put marathon runners have elevated troponin levels quite frequently. Their bodies have been under an extreme amount of stress. No one should ever run a marathon. It's not good for your body, but people do it all the time for whatever reason. Yes, marathon runners, people that have just undergone extreme physical activity could have elevated troponin levels. Good job. Finally, myoglobin. Remember we were talking earlier, myoglobin is what stores oxygen on your muscles so that you can use it. This will also peak, but this is specific to all muscles in the body, not necessarily your heart. By the way, too much myoglobin is extremely damaging to your kidneys, and this is what causes rhabdomyolysis.